In listen-only
My
mode.
name is Tony, and I will be your event specialist today. All lines have been placed on mute to prevent any background noise, and please note that today's webcast is being recorded. During the presentation, we'll have a question and answer session. You can ask text questions at any time. Click the green Q&A icon on the lower left-hand corner of your screen, type your question in the open area, and click Submit. If you would like to view the presentation in a full screen view, click the full screen button in the lower right-hand corner of your screen. Press the Escape key on your keyboard to return to your original view. For optimal viewing and participation, please disable your pop-up blockers. And finally, should you need technical assistance, as a best practice, we suggest you first refresh your browser. If that does not resolve the issue, please click on the support option in the upper right-hand corner of your screen for online troubleshooting. It is now my pleasure to turn today's program over to Laura Zeichkin, Healthier Washington Deputy Coordinator, Healthcare Authority. Laura, the floor is yours.
Thanks so much, Tony, and welcome everyone to our quarterly Healthier Washington webinar. We are going to focus today on value-based purchasing and the Healthcare Authority's value-based purchasing roadmap. Before we begin, I'd like to introduce today's presenters. I'm Laura Kate Zeichkin. I am the Deputy Chief Policy Officer at the Healthcare Authority, and today with me I have Rachel Quinn, who is our Special Assistant for Policy and Programs at the Healthcare Authority, Haley Klein, the Healthcare Authority's Medicaid Transformation Project Health Policy Project Manager, and Mary Beth Brown, who is our Practice Transformation Support Hub Director within the Washington State Department of Health. So we have a number of things that we're going to go through today that all relate to our value-based purchasing strategy. Today's webinar will quickly offer an overview of the Healthier Washington initiative for attendees who are new to this work or who need a quick refresher. We'll talk about our report on the 2016 Paying for Value survey of payers and providers. We'll then dive into the value-based purchasing roadmap that was released by the Healthcare Authority this summer. Releasing the roadmap was HCA's commitment to achieving value-based purchasing by 2021 and how we're progressively getting there over the next 5 years. We'll then discuss how this strategy is strengthened by the work occurring in our Medicaid transformation demonstration and through our partners at the Department of Health with clinical practice transformation. We've also set time aside for our panel to respond to your questions. Healthier Washington embodies our commitment as a state from Governor Jay Inslee on down to improve the health of our people and our communities. The primary objective of Healthier Washington is to transform the health system to achieve better health, better care, and lower costs for the people of Washington State. The goals of Healthier Washington are relatively simple. A healthier Washington is one where people and communities are healthier, where Washington's healthcare system delivers whole person care and addresses the needs of the head and the body in a coordinated way. And a healthier Washington is one where care is affordable for Washingtonians. Healthier Washington has multiple implementation mechanisms. Healthier Washington's work thus far has been partly funded by a 4-year, $65 million grant from the federal government that began in 2015. This grant has allowed us to move forward on a number of far-reaching initiatives all at once, all aimed at meeting the goal of a healthier Washington. Also, we just received agreement in principle for up to $1.5 billion for a Medicaid transformation demonstration. This will leverage the tools and mechanisms that we put in place under Healthier Washington to accelerate our mutual aims. Paying for value is about improving outcomes for patients and populations. It really will standardize care based on evidence. Paying for value is important to us because traditional healthcare payments reward volume of services provided, and we're really looking to reward the value of services provided. Tying healthcare reimbursement to clinical quality and patient experience and incentivizing patient-centered, evidence-based whole-person care is our goal. Payment drives health delivery system transformation, and that's what we're aiming to do through our Paying for Value goals. It drives the transformation that we want to see in our delivery system and impacts our health system overall. There are clear and powerful contrasts between the fee-for-service system, which we consider the status quo and volume-based system. And the difference is clear in a more transformed value-based system of healthcare reimbursement. You can see here what we're looking to change by moving from a volume-based system to a value-based system. Fee-for-service leads to fragmented clinical and financial approaches to care, while a value-based system creates integrated systems of care that pay for and deliver whole-person care. Fee-for-service lacks coordinated care, while coordination is very central to VBP. Fee-for-service leaves our members unengaged and left out of their own healthcare decisions. A value-based system engages members, empowering them to take a productive role in their health. A fee-for-service system creates unnecessary variation in care, and it lacks clinical or financial accountability and transparency, while a value-based system standardizes performance measurement built on a transparent foundation of clinical and financial accountability. To understand this purchasing strategy, we need to understand the key strategies that drive it. Through value-based purchasing, the state will use its dollars wisely to purchase high-value care. We're also making a concerted effort to engage purchasers, providers, and payers to accelerate transformation. And the state will align the movement occurring at the federal level. The federal government and the Medicare really aims to have 50% of Medicare in alternative payment models by 2018. We are highly engaged in their efforts around the Learning and Action Network alternative payment model framework. And we leveraged that framework for HCA's Paying for Value survey. And we've been engaging in the LAN and Learning and Action Network national committees and conferences. And we are using that framework and our own framework, as well as linking arms with the rest of the system in order to accelerate payment models and our value-based purchasing goals overall. So we do have payment models that have been implemented under Healthier Washington, and 2 of those are already operating, and we've seen success so far. We have fully integrated managed care in Southwest Washington and the state's accountable care program for public employees. The ACP program for our public employees launched in January, and we are expanding to further counties beyond the 5-county Puget Sound region in 2017. And in Southwest Washington, our fully integrated managed care model for linking physical and behavioral health purchasing launched in April of this year, and we are already hearing anecdotal evidence that it is leading to more coordinated care for people and their families. In addition, by collecting and sharing information about performance, we're making it possible for the state, payers, providers, and people and their families to see where improvement is needed. We have a variety of places where people can see this information, and we would point you to the community checkup that's released by the Washington Health Alliance as a public resource for information. Moving forward, our next step is to work with providers across the state to supply training and resources to support progress toward value-based systems. We're also working with health clinics, with rural health clinics, federally qualified health centers, and critical access hospitals to develop models for value-based payment and purchasing that will work for our safety net. Given how essential value-based purchasing is to health systems transformation, the Healthcare Authority and the state overall has committed to a leadership role in the state and even nationwide as a change agent. Rachel Quinn, the Healthcare Authority Special Assistant for Policy and Programs, will provide some information now on the current state, where providers and payers are in terms of transitioning to value, and then we'll go over our value-based purchasing roadmap and where it will take us in 5 years. Rachel.
Thank you, Laura. Good morning. It's not afternoon quite yet. I'm going to talk a little bit about our Paying for Value survey. The Healthcare Authority released the Paying for Value survey in March of this year. We released it in March and received feedback or answers in May and took the summer to aggregate the findings that we received from the survey. The purpose of the survey was twofold. One, to gauge payers' and providers' progress towards implementing value-based payments and identify barriers impeding desired progress. And two, to inform the Healthcare Authority's current and future healthcare payment and delivery transformation initiatives. Our target respondents were Washington State providers and payers. We targeted providers of all different sizes as well as payers, Medicaid payers as well as commercial. This is the second survey or Paying for Value survey that the Healthcare Authority issued. The first one was back in 2014. That was formally called a request for information. We did it in partnership with King County. But the one that we did this year was a little less formal and allowed us to collect a little more informal information from payers and providers. The survey comprised of qualitative and quantitative sections. The quantitative, as Laura mentioned, was based on the CMS Learning Action Network Alternative Payment Model Framework that they've created to define value-based payments and alternative payment models. And then the qualitative section was based off of the Washington Health Alliance Accountable Care guidelines that they released, purchasing guidelines that they released a couple of years ago. In terms of responses that we received, we received a lower response rate than we received in 2014 from payers and providers, but we did some follow-up interviews with them because we know that providers and payers have a lot going on right now, and to help get a clearer picture of where we were going. So the results on the slide show that providers were asked on to report their Paying for Value or where they are in their journey in terms of revenue, and they've reported 82% in fee-for-service and 18% in value-based purchasing. And then the payers were asked to report percentage of payments in value-based arrangements and have, in the aggregate, reported 70% in fee-for-service and 30% in value-based purchasing. This shows clear movement towards increased adoption of APMs among both providers and payers. These are higher values than we saw in 2014, which is promising that payers and providers are on their way and adopting value-based payments and alternative payment models, but still have a lot to go in terms of really moving away from fee-for-service. I want to speak to the qualitative results we saw. We saw where we asked them background questions about, organizational leadership, willingness and commitment to health transformation. We saw in our results that providers and payers are really engaged, willing to learn, support transparency efforts, committed to moving towards risk and alternative payment models with the necessary supports. that there is clear spirit of cooperation and shared governance. Key barriers that we saw across the board for both payers and providers are disparate data systems. There has been a lot of work and foundations built around IT systems, but interoperability between providers is still a big problem and barrier for sharing information. Timeliness of data, where getting data on the population that is being served is still a problem, and data is really key to entering into risk-based arrangements. And then patient attribution, understanding which patients providers are being accountable for clinically and financially. So now that I've talked about the Paying for Value survey, I want to talk a little bit about the value-based purchasing roadmap that the Healthcare Authority released in June. As Laura mentioned, and I just mentioned, we put together this roadmap because to update and braid together our different, the Healthier Washington efforts, the new Medicare, the Medicaid Transformation Demonstration Project, and to update and look at our goals and figure out where we need to go beyond our SIM grant, which is a 4-year grant until 2019. So the purpose and the goals of the roadmap are to reward delivery of patient-centered, high-value care, increase quality improvement, reward Medicaid and public employee health plans and health systems for performance, align reform efforts and approaches with CMS as much as possible, drive standardization based on evidence, increase long-term financial sustainability of state health programs, and continuously strive for the triple aim of better care, smarter spending, and healthier people. Also, inherent in the roadmap is, in terms of, in addition to the purpose and goals I just outlined, we are trying to also align our healthcare authority programs, Medicaid and PEB, and bring them closer together to a more aligned purchasing philosophy, which includes ensuring that our business is entrusted to accountable delivery networks and plan partners, and that we, the healthcare authority, exercise appropriate oversight and quality assurance over our partners. The value-based roadmap is a copy can be found on our Paying for Value webpage, on our Healthier Washington webpage. And I want to point out that our value-based roadmap will be continuously updated over time, given all the changes that are rapidly happening, and especially with the Medicaid Transformation Project that was just awarded. And here are our purchasing goals. These have been updated since we received our SIM grant. So by 2021, 90% of state-financed healthcare, so our Apple Health Medicaid program and public employee program, and 50 to, we've updated that, or in the process, 50 to 75% of commercial healthcare will be in value-based payment arrangements. And we mean, this is measured at the provider level, our provider payments linked to quality and value. And then Washington's annual healthcare cost growth will be below the national health expenditure trend. These, I want to point out that our goals are very much, are very similar, almost identical to the federal Medicare purchasing goals. We had released our purchasing goals when we did our innovation plan and when we received our Healthier Washington grant, but our purchasing goal is the exact same. For example, for 2018, Medicare has come out and stated, put a stake in the ground that 50% of Medicare payments will be tied to value-based payments, and we have also said have set a similar, the same goal, which further demonstrates that we want to be, we want to follow their lead as much as possible and align as much as possible in terms of their purchasing strategies. So when we talk about contracting for value, that we have some common, there's some common elements across our different payment arrangements or value-based payment arrangements. And these 5 are foundational elements that will be seen across as we spread and scale our value-based purchasing through Medicaid and PEB. But these 5 components will be seen throughout our value-based purchasing contracts. And for example, because the accountable care program's kind of on the ground, has been launched and has about 10 months, has 10 months of experience, I'll show examples of what we mean by these components and how they're factoring out in reality. So first is shared risk. Providers and payers, if in the arrangement, there needs to be kind of clinical accountability and financial risk and shared risk with the payer, which is us. So under the accountable care program, we have agreed to a trend, and if our accountable care program come in under the agreed upon trend, we owe them money, and if they're, if they're under, we owe them money, and if they're over, they owe us money. But there's this, it's not just paying for volume. It's really, they are accountable for the costs that they are delivering, the care that they are delivering. Member experience is also very key, and there are some risk sharing or gain sharing for quality measures around member experience. The accountable care networks have put in place enhanced strategies for access to care. Urgent care clinics have expanded hours. They have a dedicated call line for members because we want members to make it as easy as possible for members to get care and appropriate care, especially ensuring that they use primary care as their the locus of where they get their care. Care transformation, because we're changing the way that contracts are paid, that means that care needs to be redesigned to meet the quality and outcome goals and performance measures that we are requiring. So our care transformation approach is we want the care to be guided by best practice guidelines. The BRE collaborative, a multi-stakeholder collaborative that is in Washington State, has come out with best practice guidelines, which are based on evidence, and we want healthcare to align with those best practice recommendations in our accountable care programs as well as our other state finance programs. Timely data, as I mentioned before, data is really key to ensuring appropriate care, and that providers have the tools to take care of patients within their system and outside their system. So under the accountable care program, we are working with our third-party administrator and a data aggregator to ensure that the provider systems have have data daily, weekly, monthly, to understand for direct care, and also for population health analytics to help them strategize how to make sure members are getting the appropriate care. And then the last is benefit design. Benefit design is really important to incent appropriate health behaviors that we want to see. So under the accountable care network, we have made primary care visits free to emphasize the importance of primary care. We've also made cost sharing is different and lower for this program, so members seek appropriate care. I'm now going to turn it to Kaylee Klein.
Rachel, I might stop and just ask a quick clarification question. When we talk about our purchasing goals by 2021, and also where we currently stand based on the survey results, how are we measuring that? And are our goals related to dollars or episodes?
Well, we measured it differently for providers and for payers. So there were different templates for each of the different stakeholders. So providers were asked for them to report on their revenue. So what percentage of their revenue is in the different land categories. And then the payers is based on payments to providers. Are they in where are they in the land categories? I think that addresses that question.
Yes, thank you.
Okay, so Medicaid transformation. As Laura had mentioned earlier, we recently reached agreement in principle with CMS on a 5-year Medicaid demonstration. This allows us to invest in innovative activities and services for our Medicaid program. And as a reminder, there are 4 fundamental goals in our transformation, Medicaid transformation efforts. So first, we want to reduce avoidable use of intensive services and settings by focusing on better interventions, better primary care, and a better organized delivery system. We also want to improve population health by looking at total population health improvement and recognizing the system levers that have to be pulled to achieve that. Third, and the focus of today's discussion, we want to accelerate the transition to value-based payment. We want to reward value and outcomes, not volume and widgets. And finally, if we are successful in the first 3 goals, we want to bend the cost curve, meaning we want the Medicaid inflation rate in this state to be below that of national trends. As mentioned, accelerating the transition to value-based payment is a fundamental goal of the state. It is also an expectation of CMS for the Medicare and Medicaid programs. They are very interested in making sure that through the Medicaid transformation demonstration that this is a key focus for the federal investment, that we have the opportunity to invest in our system. This means that our efforts must contribute meaningfully to moving Washington forward on value-based payment. And importantly, this movement towards value-based payment models is critical to the success and sustainability of our efforts and activities within Medicaid transformation. Paying for value across the continuum of Medicaid services is necessary to assure the sustainability of the transformation projects undertaken through this demonstration as envisioned under Initiative 1, Transformation Through Our Accountable Communities of Health. So we do plan to leverage this 5-year demonstration to make significant investments in provider, plan, and state capacity to convert our volume-based payment system to one that rewards value. So that is just the quick link here that the efforts within Medicaid transformation very much tie into the broader Healthier Washington goals of paying for value. And with that, I'm actually going to transition to Mary Beth Brown, the Practice Transformation Support Hub Director.
Thank you, Callie. So in the midst of all of this activity, the Practice Transformation Support Hub is being stood up as an ally and a support for providers. So we know that with this value-based purchasing roadmap, every practice and provider has to chart their own course and decide when to get on that roadway and be part of healthcare transformation. So recognizing that practices and providers are at different places along that practice transformation journey, the hub is targeting its resources to the small and medium providers. So those practices with 20 or fewer providers, and we will reach out to primary care, behavioral health, so both mental health and chemical dependency practices. How will we do that? So we've recently brought Qualis Health under contract with us to provide our practice coaching, facilitation, and training program, as well as our regional health connector project. Let's go back to the strategy slide. So what we'll be offering is intensive coaching to advance behavioral health integration for enrolled practices. We'll offer regional trainings and then technical assistance and referrals for those practices that don't want to engage in intensive coaching for those small and medium practices. And then we'll also be standing up a web-based resource portal that will have curated resources that are timely and relevant that will support practice transformation, and that will be led by the University of Washington. So our approach as we roll out our services is we will be prioritizing our coaching resources to those regions, sort of regional service areas and accountable communities of health, that have stepped up as early adopter and mid-adopter regions. So because the coaching, the intensive coaching will be targeted toward the integration of behavioral health, we will be following Payment Model 1 and supporting those regions that are moving toward behavioral health integration. And then we'll also prioritize practices that step up around the state for the other models that come online from Healthier Washington, whether it's for F2HCs, rural health clinics, or others, and make sure that coaching supports those practices that choose to pilot our models, payment models. We know that practice transformation has been going on in the state of Washington for some time, and that there are many initiatives, and you've heard a lot about different activities around the state. So we wanted to clarify for you that we have multiple initiatives happening. Ours is through our state innovation model, the Practice Transformation Support Hub, but I'm sure you've heard from some of these other initiatives that are funded through the Transforming Clinical Practices Initiative, which is also federally funded. So we have both the National Rural Accountable Care Consortium that is enrolling practices primarily in Eastern Washington, and then also we have the Pediatric Transforming Clinical Practice Initiative, also led by the Department of Health as the Practice Transformation Support Hub is, that's working with practices primarily focusing on improving care for kids. Peace Health and University of Washington also have TCPI initiatives active in the state. So our hope is to get guidance from our project officer that we will be able to bring hub resources to all practices that are in those targeted practices of 20 and fewer providers to fill the gaps that maybe any of these other initiatives are not addressing for those practices, so that we would be able to bring resources wherever a practice needs us. We haven't yet gotten that guidance, but we're working on that. Our timeline for rollout, we just brought Qualis under contract recently, but they will be active in November, beginning their recruitment into intensive coaching services. And as I said, we'll be prioritizing those regions that are engaged with Payment Model 1 for the integration of behavioral health. Also in November, Qualis will be rolling out the Regional Health Connector Network. They will be doing it one regional service area at a time. And then we also, by the end of January, hope to have the first version of our web-based resource portal online for use to support practice transformation for any and all comers. We also expect by the end of January to hold a regional training with the UW Ames Center that will be open to a broader audience where we can address value-based payment and behavioral health integration issues. So with that, I think I'll turn it back to Laura for questions and answers.
Great. Thank you, Mary Beth, Kaylee, and Rachel. This concludes our formal presentation for the webinar today. We now want to leave plenty of time for questions and dialogue from you. So just a reminder that you can submit questions by clicking the green Q&A icon on the lower left-hand corner of your screen. So we did receive throughout the webinar a couple questions. Namely, we received questions about our accountable communities of health and how they play into our goals around value-based purchasing and paying for value. As a reminder, our accountable communities of health are voluntary, regional, multi-sector collaboratives that are aligning resources, priorities, and action at a community level. We have 9 accountable communities of health statewide that have been designated and are moving forward with action and are linked to Healthier Washington in many ways. So how do ACHs fit into our paying for value strategy? I have a brief remark, and then I'm going to turn it over to Kaylee and also Mary Beth. So our accountable communities of health, as I said, really are tasked with identifying and taking action on the health priorities of the community. That includes the priorities that are brought forward from those sitting at their table, such as providers and plans. As plans and providers move forward with value-based purchasing targets, and particularly aim to move the needle on specific measures that they're incentivized to advance, our objective is that accountable communities of health will work together to leverage the resources, including clinical resources, those that the plan can bring forward, and also those out in the community, such as public health, nutrition services, transportation, housing, you name it, to really take a triple aim approach, if you will, to addressing addressing those measures of performance that we're putting in our contracts and incentivizing in state finance programs. We also hope, as ACHs advance, that their tables and the number of sectors and multi-payer participants in particular will increase, and the ACHs will be able to address not only the incentives that are included in state financed programs, but also reach out and support the commercial sector. To get a little bit more detailed, we have outlined a potential role for ACHs in advancing VBP for the Medicaid transformation demonstration, and so Kaylee, I'm hoping you can speak to that.
Sure. So Initiative 1 of the Medicaid transformation demonstration is really focused on activities that we can undertake to help support and transform the delivery system, particularly focusing on how we deliver care to our Medicaid populations. We cannot transform the way we deliver services, however, without changing the way we pay for them. So the activities and the projects within Medicaid transformation will certainly have to be linked to the activities under value-based payment models. With that, ACHs play a leading role in coordinating and monitoring the transformation projects, and will be in a position to determine how incentive payments can be directed to those providers undertaking new value-based payment arrangements. So certainly as it relates to Medicaid transformation specifically, the role and responsibilities of the ACHs will likely become clear as we continue to build out and refine the Medicaid transformation toolkit over the coming weeks and months as we continue the special terms and conditions negotiations with CMS prior to officially implementing and launching the Medicaid transformation demonstration.
Great, thank you, Kaylee. We also are linking our accountable communities of health and our practice transformation support hub through, as Mary Beth outlined, regional health connectors. One of the goals of the hub is to support providers in skill and capacity building as we move to value-based systems. Mary Beth, I'm hoping you can speak to some of the intersections or envisioned intersections between accountable communities of health and the hub.
Well, we think of the hub's resources as being allied with the provider community and the ACH managing at the systems or community level, but the intersections that we're exploring would be getting help identifying providers and practices that would be interested in enrolling and coaching and getting help with recruitment, as well as supporting the regional health connectors who are going to do a scan of what kind of community supports are available to providers to bring inside the clinic walls so that the community clinical linkages are strengthened. So we don't want to be reinventing the wheel, so we want to draw on the resources that are in the community and would rely on the ACH to bring those resources to the hub. And you know, there will be other, I think providers are participating in the ACHs, but the hub will stay with the individual practices primarily.
Great, thanks Mary Beth. Sticking with you, Can you talk a little bit more about the items that will be available on the Hub's portal?
As the UW team is working on the content for the portal, we see three core content areas. So support for providers around BBP, so information about MACRA as that comes to its final rule, and information about Healthier Washington payment models would be highlighted on the portal. We would also have information about behavioral health integration and templates and tools that could be used. We envision toolkits that would be tailored to the different practice roles in a practice setting. And then we also hope to integrate the Department of Health's plan for improving population health into the web-based resource portal, so it would strengthen what the actions can be for health transformation that can be taken at the community level and by individual providers inside the clinic, and help to link those so that they move the whole community toward better health outcomes for the community.
Thanks, Mary Beth. We received several questions about measurement. I'm hoping, Rachel, that you can speak to how we are using our statewide common measure set, both specifically in our payment models like the Accountable Care Program, and also how we're using it to drive toward more of a value-based system overall.
Sure. So some background on the Washington State Common Measure Set. We, under Healthier Washington, created a common measure set to send a common signal to providers and purchaser of care to use common measures in purchasing. So the common measure set was created by a governor-appointed committee, and they meet on a regular basis to update the measure set. But the measure set also is we're using in our value-based purchasing arrangements to measure and reward performance of providers. So under the Accountable Care Program, which we launched in January for public employees in the 5-county Puget Sound region, in addition to a shared risk arrangement, we have a quality improvement model arrangement where the networks can receive additional payments for quality improvement on 19 quality measures. And those 19 quality measures are a subset of the Washington statewide common measure set. And all 19 are very much focused in primary care. So I believe there's 4 diabetes care measures, 2 depression medication management measures, 4 or 5 screening measures where both networks will again reap will have incentives to improve and reach national targets that we have set for them based on performance nationally as well as regionally. And then under the roadmap, we have outlined changes for our BBP changes for Apple Health arrangements. And in those arrangements, we have outlined 7 quality measures, again, from the Washington State statewide common measure set, almost identical to the measures being used under the Accountable Care Program, but Medicaid providers will be held to those measures starting in 2017, and we'll be able to get back some of a withhold depending on their performance and improving and meeting targets for those 7 quality measures.
Rachel, we had a question about meeting those targets and really making this transition from a volume-based system to a value-based system. Can you expand upon that a little bit more, particularly within the Accountable Care Program, how we are rewarding for improvement and performance?
Sure. So we all recognize that this is the transition to value-based payments. It's not going to happen overnight, and providers, as I mentioned on the survey, are are very much making the journey towards that value-based payment arrangements, but they're still very much a fee-for-service. So we are we want to measure in terms of value-based care, we want to reward value, which includes quality. So we can't reward what we can't measure. So we're starting to use the common measure set to measure care and then reward care appropriately. So we have, so for example, we have said to the practices, it's not all about just are you hitting a target of 80% of where we want you to be. We also want to reward any type of improvement. Providers of all sizes are it's very across the map in terms of performance on screening measures, including breast cancer screening, chlamydia screening, and diabetes measures. So in our accountable care program contract, we have structured the arrangement that they not only get incentives for meeting these targets, national set targets, but we're also, they will get extra incentives for even improving and moving the needle on improved care.
Thanks. Mary Beth, can you expand a little bit on your comments around the alignment between the Practice Transformation Support Hub and the other practice transformation initiatives in the state? Particularly, how can interested providers engage in one or many?
Well, I would say for any practice that fits that targeted profile of fewer than 20 providers, please do contact the hub if you are interested in enrolling in intensive coaching services. We are working with the federal government to ensure that if we do enter into a practice where another initiative is present, that we find a solution to not duplicating effort and using duplicating effort with federal resources. So we want to solve that problem at the clinic level, and we're hoping that each practice will be able to select from a menu of services and just ensure that what you're working with Qualis on would be different than you might be working on with the National Accountable Care, Rural Accountable Care Consortium or with the Pediatric TCPI initiative. So please do contact us. We're still seeking guidance on that, but we're working to make it possible for you to access the services you need to support your practice transformation.
Great. Thank you, Mary Beth. Looks like we have another question about the Department of Health FAQ for the Practice Transformation Support Hub. What resources are available for people to learn more?
We are in the process of developing some FAQs that were brought to us by the Accountable Communities of Health about the hub, and we expect those to be up and online, shortly in the next week to 10 days. We just brought Qualis under contract, and we were thinking through our strategy of rolling out the hub, and so we want to be clear on that before we release our FAQs.
Great, thank you. So Rachel, you talked about the value-based purchasing roadmap and signaled some of the current activities, but can you preview a little bit for us what else is going on in this space and what folks can continue to see as we continue to roll out models from the state finance program?
Sure. So just to do another little level setting, so under our Health Through Washington, or under our SIM grant, we had 4 payment models. And one focused on integration of physical and behavioral health. The second one, Encounter to Value, aimed at critical access hospitals and federally qualified health centers. The third one focused on building an accountable care program for public employees. And then the fourth one, working across payers, aligning across payers to accelerate value-based purchasing. But again, to reiterate, we put out the roadmap in June because we have a lot of other efforts going on at the same time outside of our Healthier Washington, our SIM grant, our 4 payment models. And one program is our Centers for Excellence program and bundled program. So starting in January, and this is on our public employee side, we have designated a Centers of Excellence. One, Virginia Mason Medical Center in Seattle has been designated a Center of Excellence for total hip and total knee surgeries. So what does that mean? That means that public employees will have a choice to go anywhere for their a knee or a hip replacement. But if they go to Virginia Mason, they will not pay anything. Virginia Mason has demonstrated clinical quality and excellence in this area. They have offered bundled, there are Center of Excellence for other large national companies. And so we want to move the needle on, and we want to reward them for providing excellent care, and we want our state employees to have excellent care. So we have that program starts in January. We are currently looking at what building out that Centers of Excellence program for 2018, and we are in the process of selecting a new topic for that, looking at what the BRE Collaborative has recommended in spine care or cardiac care, and as well as what the Learning Action Network has recommended and produced white papers on what how to standardize care in different disease focus.
Great, thanks. So as we make this transition, we have multiple settings and different types of providers. Mary Beth, I'm wondering if at a clinical level, and as we think about the transition from volume to value, how we're supporting our rural providers so that they don't kind of drop through the cracks, and also ensure that we're supporting their business models as we change our expectations.
Well, I think the hub heard in our listening sessions last year about that very important concern that we keep our rural providers vibrant and retain access. So Qualis is aware of the different environment that they will walk into a critical access hospital or a rural health clinic, and so want to tailor their coaching to match the setting. So simplify the changes to the infrastructure and work with the resources that are present, and allow the rural health clinics and the critical access hospitals to chart their own course, which would be very different than a larger system. So the expectations would be different, and the coaching engagement would be negotiated, and something the coach would work with the leader in the clinic or the hospital to decide upon. So the action plan would just be very, very different and would support that rural setting.
Thank you. Rachel, we've talked today a lot about state finance programs and how through Medicaid, our public employees program, and alignment with Medicare, how we're really looking to serve as kind of state as first mover in this transition to value. I'm wondering if you can speak to the importance of engaging the commercial sector and how purchasers and others in the market can join us in making this transition.
Sure, I'm happy to. So as most people know, Healthcare Authority, we're the biggest purchaser in Washington State. We spend $10 billion a year between Medicaid and the Public Employee Program for 2.2 million people. But we can't do it alone. So we are taking significant steps to change our own purchasing to drive new models of care. But we need other purchasers who have left purchasing power to send similar signals on cost and quality to their payer partners and provider partners. So through the for our accountable care program, we have posted online the contracts or the request for proposal that we use to select the 2 accountable care program networks, as well as our redacted contracts, because it's our intention for other purchasers, commercial or public, otherwise, to adopt strategies that, as I talked about, the foundational elements. So whether it's building, having a direct contract with 2 delivery systems, 2 accountable care networks, whether it's how to, contract language on pushing out quality metrics into contracts. We have posted our contracts online to help facilitate that and help other purchasers do the same.
Thanks, Rachel. Things are moving quickly with Healthier Washington and health systems transformation generally in Washington State, but maybe the Medicaid transformation demonstration is a good example of how things are evolving really quickly. Kaylee, can you speak to the process for the next several months in the development of the special terms and conditions, and how our partners can expect to kind of stay up to date on the process?
Sure. So where we are right now, we are still waiting for further direction from CMS as to how the process of STCs is going to unfold. CMS is responsible for the drafting of the special terms and conditions, so we ourselves will not see those until CMS works through that process on their end. So as we get more information, we will certainly keep our stakeholders and partners updated on how they can stay informed and up to date on that process. We will continue to leverage the Medicaid transformation website, also a page on the broader Healthier Washington website to keep everybody updated, as well as utilizing the feedback blast to get updates out as well. So there will be a lot of work occurring over the coming weeks and months, both through the special terms and condition process, and then actually even after that process, there's another phase of work where a lot of the actual programmatic details get ironed out once we get past some of the more contractual language elements that are in the special terms and conditions. So the next couple months will be really focused on some of those more technical contractual pieces, and then we will start to get into a deeper dive on the details, both from the services side and the programmatic pieces of Initiative 1. So a lot of developments. Continue to go back to the website for updates.
Thank you, Kaylee, and thank you again to Rachel and Mary Beth for providing valuable information today. And thank you to those who were able to join today's webinar. We very much appreciate you tuning in on a quarterly basis to dialogue with us and learn about Healthier Washington and its initiatives. Slides from today's webinar will be posted on the Healthier Washington website on our meetings and materials webpage. Also, please join our Healthier Washington feedback network to get notices of the posting of the slides, as well as information on all of the efforts that you heard about today. If you have any questions about the Practice Transformation Support Hub, the Medicaid Transformation Demonstration, or our goals around value-based payment overall, please do not hesitate to email us at the email address you see there, and also please check the website. Thanks again, and please join us next quarter.